Thank you all for being here and welcome. I'm Renee Bartlett-Weber, and we put on monthly events and develop package resources that you can find at calmatters.org/forlearning. So today we have a really special event, and I'm going to pass it over to our reporter, Kristen Hwang, to get us started.
Thank you, Renee. My name is Kristen Hwang. I'm a health reporter here at CalMatters, and I'm very excited to do this event today with Assemblymember Mia Bonta. Since we don't have that much time, I'm just going to launch right into it. This event is going to be about maternity care access, and we'll do a deep dive into some of those issues. But just to kind of set the stage for everybody, several weeks ago, the state released a report on the current state of maternity care in California. And the first sentence of the report said, and this is a quote, "Every 5 days, Kristen loses their life to pregnancy-related complications." End quote. That's a very sobering statement. And it's one that also coincides with the loss of maternity care across the state. Low-income areas and Latino families are the most likely to live in areas with limited access to maternity care. And today there are 12 counties in the state that have no hospitals in which to give birth. So this morning, we will dig into those reasons and, the impacts of those maternity care deserts in California. I am joined by Assemblymember Mia Bonta, who's a lifelong civil servant representing District 18 in the East Bay. Thank you so much for joining us today.
Thanks so much for focusing on this topic, Kristen, and for having me.
So let's dive right in and let's start personal, because birth is personal. You're a mother and, a proud Black Latina. You've been involved for a very long time. How does your experience shape how you think about this issue in California?
There are a couple things that just come to mind. One is my 3 kids and my own birthing experiences with all 3 of them. I had a kind of emergent births for each of them. I also think about just the fact that I've experienced directly racial bias that exists in our healthcare system and in my own birthing experience, and how traumatizing that was, and to be put in a position where I was not listened to and not believed because of my ethnicity and my background, which was just really troubling. And the one that probably hits home the most is I'm a mother of daughters. And right now, our daughters have fewer rights in this country than I did growing up. It breaks my heart. So as a mother first, I'm deeply concerned.
I'm glad you brought up so many, issues that we'll touch on in this conversation. I'm, specifically brought up the racial bias and how that can impact outcomes, as we know that Black women in California have, between 3 to 4 times higher mortality than their counterparts in the state. So let's talk a little bit about some of the reasons for why maternity deserts are growing across California. In my reporting, I found that it's a very complex issue, and I know it's something that the legislature has considered for a couple of years now. Can you sort of walk us through, what are some of the top line reasons for why this is happening in California?
The reality is that in the state of California, and quite frankly across the United States, we haven't valued birthing and mothering, and we apparently haven't created a healthcare system where the bottom line doesn't pencil out, so that people are investing in maternity wards and labor delivery units and perinatal units, and that is proven out by the fact that in California, Medi-Cal is the 5th lowest reimbursement rate for obstetrics in the United States. So we have a fundamental inequity built into the way that we fund and prepare for and reimburse our maternity wards. And so it's not surprising to me that it becomes very challenging for hospitals across the state. And we also have another issue with the kind of the alternative methods of being able to provide safe places to give birth. And we'll talk about that a little later. But I think those 2 issues just at the end of the day, we don't value it enough, and we don't fund it at the level and reimburse it at the level that we should. It impacts our healthcare workforce and our ability to make sure that we have nurse practitioners, doulas, midwives, doctors who are focusing on obstetrics and gynecology that are actually offer culturally concordant care because they come from the experiences of people who need the help most. So it can be very complex, but at the end of the day, we just need to take care of our moms more.
Mm-hmm. Yeah, I know, especially just thinking about everything that's happening federally and also with our state budget process, I think it's important to remember that like budgeting at the end of the day is about values and about choices you want to make. And that, you know, that low reimbursement rate, I think is also especially important in California, considering that Medi-Cal pays for half of all births in the state. And so that is, you know, has a big impact on the hospitals. I'll also just note that a couple other factors, you know, birth rates are at their lowest level in California in a century. And for hospitals, you know, low volume can also cause safety concerns if you have providers that are not doing births frequently enough. And you mentioned workforce as well. The California Hospital Association released a report on sort of maternity care and the challenges hospitals face. Just 5 years, California will have a shortage of 1,100 obstetricians. So those are some of the, you know, very sobering facts that we're faced with. And yet at the same time, you know, people will always need safe places to give birth. So I want to move us into some of the things that the legislature has done and some of the, you know, proposals that you've put on the table this year. Last year, there were 2 bills aimed at slowing the closure of maternity wards, one of which was signed, and both were sort of, to vastly oversimplify, advance notice requirements to sort of help policymakers intervene if they had the ability to. This year, you've introduced legislation on a number of reproductive health issues, including birth centers, which are separate from hospitals.
Yeah. So this year, I introduced as my first set of bills a package that focused on all aspects of making sure that we have equitable access to healthcare around family planning. AB 40 focused on making sure that hospitals actually are providing and clarifying that EMTALA, the Emergency Medical Treatment and Labor Act, is something that hospitals needed to follow so that women wouldn't find themselves having to go into sepsis or incredibly urgent situations while they were pregnant in order to be able to get basic emergency care in our hospitals. So we're clarifying that. AB 50 focuses on over-the-counter birth control bills, and AB 55 focuses on the ABCs, alternative birthing centers. That is really driven by the reality that over the past couple decades, we've had an inability to really create places where people can give birth, and that there's great disparity in it. We actually only have 4 remaining alternative birthing centers in the state of California. And in order to be able to be a licensed alternative birthing center, the primary driver for that is so that you can be reimbursed through Medi-Cal or through private pay insurance. And so the fact that we don't have licensed birthing centers means that we're tamping down on another opportunity to be able to have safe deliveries. And there's incredible disparity with that because we actually do have 23 unlicensed facilities throughout the state of California, and those are for people who have the ability to have private pay experiences for giving birth. And that's just not right. So we introduced AB 55 to ensure that we have alternative birthing centers because they have an inability to get through the permitting and licensing process or pay the upfront cost to be able to meet the requirements that are often murky and unclear or inaccessible. And that causes us to not be able to establish them or keep them open or be sustained, and eventually means that we won't have the access that we need in urban and rural areas to be able to ensure that we have at least one other option to be able to ensure we have safe care for people who are giving birth.
Mm-hmm. Yeah, when you talk about the complexities of trying to get licensed as a birth center, just as an example for the audience, I in my reporting, spoke to a licensed birth center in San Francisco. They said it took them 4 years to get licensed to do the whole the whole application, because it was just, the process was so complicated. There were so many hoops that they had to jump through. Also, just say for the audience that birth centers and licensed midwives can handle low risk, uncomplicated births for people who want to give birth in that setting. Midwife deliveries are standard in many other developed nations. And there is, a lot of survey evidence also in California specifically that people of color, women of color, are the ones who are the most likely to want to give birth in that setting, but are unable to pay for that, either because they don't have insurance or because the birth center doesn't take insurance. So we really have, as you noted, Assemblymember, struggled to maintain birth centers as well as hospitals. I think you noted that there are only 4 licensed ones in the state right now. Yeah, the closures are also happening rapidly. I think there have been at least 20 closures in the past 4 years in California. Can you talk a little bit more about, how the birth centers fit into the reproductive health landscape and why you decided to focus on those?
I think that they are just, as you shared, kind of an option that many birthing people, mothers, want to be able to have, particularly from a perspective of supporting Black and Latino and BIPOC moms who want to be able to have an experience that ultimately actually leads, as research has proven, to better health outcomes, lower rates of cesareans, higher success rates for breastfeeding, fewer low weight births, fewer preterm births. So it is a very viable option for low risk births and people who just know that they want an experience where they will be seen and heard and have an experience that feels more connected and holistic and leads to better health outcomes. So they're very, very critical for us to be able to have as a part of the landscape, especially in light of the fact that we have so many more costly, essentially, labor and delivery units closing at rapid rates that are just not sustainable. If we can maintain the path that we are on, the landscape that we will be facing in probably not even 10 years, is that we will not have women able to give birth in places that are safe. And so we have to do something with urgency, but then also present alternative options and have a robust set of facilities and settings for people to be able to give birth. So they're pretty crucial at this time.
Yeah. In my reporting, I found that, maternity deserts in California, they're growing not just in rural areas of the state, but also in urban areas and historically marginalized communities as well. Low-income Black and Latino communities, they're much more likely to lose their local maternity ward than others. I think it's around 20% more likely. And of course, I know you shared at the beginning with your own personal story experiences of bias in the birth setting. Can you talk about, sort of that entrenched, sort of unconscious bias and these disparities in access?
I think you spoke to it a good bit just in thinking about the pipeline of obstetricians and gynecologists that we have. We already know nurse practitioners. We already know that we have a crisis in terms of the healthcare practitioners that need to be made available to us. And it's not just the sheer number, it's also who those people are, right? We know, and research bears out, that when you have an individual who comes from a similar background, who has language concordance, who has cultural concordance with the patient, that patient is going to be receiving better care, essentially. Care that they can trust more, care that they can be connected to, because there's resonance between them and their healthcare provider. So off the bat, because we have this challenge around our pipeline and our workforce, we are already in a crisis mode. And what that means is that we have more interactions with healthcare providers as patients, where there just isn't the matchup and there's not the kind of trust that we need. And we need to do everything we can to promote that. Being able to create alternative birthing centers and focus on very proactive programs that do focus on maternity ward and delivery programs, with an intentionality around inclusion and diversity and equity. I will say those are diversity, equity, and inclusion and access within the healthcare space is incredibly important. I am really fortunate to represent 8018, which is Oakland, Alameda, and Emeryville, and we have some of the strongest programs, Sutter Health, that have really made very strategic investments in building out their inclusive programming and interventions and supports for all people who are giving birth and who are going through the process in terms of perinatal care and the actual experience of giving birth and then postnatal care as well. So we have a long way to go, but it's the thing that will keep us all healthier.
Speaking of your district, I believe you've visited one of the local maternity wards recently. Is that correct?
I did. I think I went to Highland Hospital recently. Very well-established hospital in our community that has at different times struggled with staying open, and thankfully they are there and strong and doing really well right now. We toured their labor and delivery unit. That ward was completely full, and they reported an increase in the number of deliveries that they had been experiencing over time. So we know that in pockets there is still incredibly high demand. So that's also of concern.
Yeah, that's a good point to bring up, that I think I had mentioned previously that, birth rates are at the lowest point they've ever been in like 100 years in the state, but it's not an even decline, that there are definitely parts of the state where birth rates are increasing. And, also with the impact of services being lost in other areas of the state, certain hospitals are seeing, drastic increase in the number of deliveries. I want to return to, I guess, the workforce issue, because you mentioned, the importance of having a workforce that looks like the people that they're serving. The legislature has taken and the governor has made quite a few investments in the past few years in the healthcare workspace. Can you just give us some, top line items of like what those investments are trying to accomplish, how we're trying to improve the healthcare workforce?
Yeah, I think one of the things, I think one of the most monumental things that the legislature has done, and we fought really hard for with our labor partners, was to ensure that we were providing a thriving $25 an hour wage to our healthcare workforce. I think it's really hard. I think I'm on my way to a political action shortly to know that we have been building our healthcare system on the backs of workers who have not been able to thrive in their everyday with their employers because we haven't been paying them enough. So we're able to focus on that and make a big investment, and that was a very hard fought decision that we were able to have happen in the legislature. We've also made recent investments in having a master plan around career and technical education training. And I think that really has brought to light our need to be able to build out a healthy pipeline in different areas, nursing, healthcare practice, and other areas. And I think that's been really critical for us to just take a very clear-eyed look at whether our educational system is, TK through community college, our CSUs, our UCs are really being built to produce the workforce that we need to be able to sustain what we need. different space, not related to maternity wards, but one of the most troubling factoids that I got put in my head when I became health committee chair was that we needed to have 10,000 healthcare practitioners to work in skilled nursing facilities in order to be able to handle our silver tsunami as our elders are aging and often cannot age in place for a set of reasons. So we're seeing across the board in all kinds of aspects that we just need to make more investments in our workforce and change the conditions in their hospital settings. Can't tell you how many folks I talk to who talk about being overworked, overscheduled, not having the pay that they need, not being able to live near where they work, and the impact of that has on their own life. And ultimately, what it all boils down to is the impact that it has on patient care. If you are having to interact with a healthcare provider that has to be unhealthy in order to be able to deliver their support of you, that's not a good thing.
Yeah, it is really challenging. I know that the workforce challenges have been exacerbated, especially it's still in this, post-COVID world, because there was so much burnout, and there was already a cohort of people in the medical world that were sort of on the verge of retirement, and then COVID hit, and everybody fled. So that's definitely something I know the legislature is always working on. We have a few audience questions that were submitted, and I think in the remaining couple of minutes that we have, we might be able to take one or two. One of the questions is, how do you see policy aiding or bridging the gap between when a community hospital or an acute care hospital, I think, closes their maternity ward and sort of ensuring that there are safeguards in place to prevent the abrupt closure of a maternity ward?
Yeah. I think, Kristen, you mentioned a couple of the pieces of legislation that had to do with noticing last year, which is tricky, right? A hospital never wants to signal that they are closing down their maternity ward, because then it immediately means that people will start looking for other opportunities, causing that maternity ward to have an even more precipitous closing. But at the same time, we have to give notice, because we have to be a lot more regional in our thinking about what kind of network of care we're providing. So I think from a policy standpoint, there's a lot that we can do. I think we have to set the bar higher than just notice. I know that there's a few pieces of legislation that are going to be going through our committee coming from the Senate. I think Dr. Weber Pearson is carrying a bill this year to that end that are really going to focus on creating more than just noticing, creating kind of a standard of practice, and asking our hospitals to set protocols as well as kind of an evaluation metric around why they're closing and whether or not they need to. And if they do, what impact that has on our other systems. So I really see our ABC bill, the alternative birthing center bill, and the legislation that will be happening kind of working in partnership together to really strive to create more of a holistic and regional look at making sure that we have the access to care for people who are going through the birthing experience.
Mm-hmm. Yeah. You mentioned the word regional, and that reminds me that I am not the expert, but when I have spoken, with people who think about this day in and day out as their job, I think regionality is one of the ways in which hospitals are potentially starting to rethink maternity care. Like, how can they work together? Can they have sort of a hub and spoke model, and sort of how can the state, also support those changes, given what we know about like investment in women's health and things like that. We have 1 minute left, so I think I will leave it there. And thank you very much, Assemblymember Bonta, for joining us today at this CalMatters for Learning event. And thank you also to the audience for spending your time with us this morning. Yeah. that's all.
Thanks so much. Let's keep on having healthy babies.